Hello, everyone. Could you somebody put a thumbs up if they can hear me? Thanks, Mark. Okay. Just at the moment, Catherine's just having a few issues getting in. There's a firewall issue from her trust, so she's just trying to log in at the moment. So we may be just a few minutes late, but in the meantime, I'll wait a couple of minutes and then I'll start it off. Okay, good afternoon, everybody. I'm not 100% certain whether Catherine's been able to join as yet because I'm online and I can't see whether she's been online yet. Catherine, if you're there, can you holler, please? Oh, hello, Catherine.
Hello. I think I'm
Hello.
here.
Hi. No, yes, you are. Yeah. Thanks a lot for coming, Catherine. If I just introduce you and just go through a few things, and then we can start kick off. So, um, I'll start again. Good afternoon, everyone, and welcome. And thank you for joining the webinar today. I'm sorry it's a little bit late, but everybody knows what IT is like, and I think we all need a 5 or 6 year old child to help us with IT nowadays because they seem to be a lot better at it than us. But anyway, I'll carry on. As we know, sort of global warming's having an impact on the epidemiology of infectious diseases across the globe. And as we seem to be wanting to warm up our planet, the vectors of a number of tropical diseases are now actually on our doorstep. And to add to this, as we recover from the pandemic, we're jumping on aeroplanes and starting to travel the globe again. And it's probably now is the time to get a little bit smarter with some of these tropical diseases that are coming to our shores. And today we're lucky enough to have an expert in this subject area with Dr. Catherine Moore from Public Health Wales, who's going to talk to us about unwanted holiday souvenirs. Just before we start, if anybody does have any questions, and I'm sure there'll be lots, please put them in the chat and I'll try and collate them and hand them over to Catherine towards the end. And after all that, I'll pass over to Catherine, and I'm really looking forward to this talk, Catherine. So I'll shut up now and pass over to you.
Thanks. Hopefully you can share my talk.
Oh, yes, I can. Yes, I will do that. Yeah.
Yeah, it's because my IT is so awful at the moment. I didn't think it would be worth trying to share my screen because otherwise it just won't work. So just to sort of like sort of lay some sort of truth in what's saying it. So I wouldn't say that I'm a complete expert in this area. What I would say is that I have an avid interest in it because I think, we as virologists and various people sitting in this meeting will know we've had a bit of an interesting 4 years with emerging infections. And so what I'm looking to is the future, and to try and prepare ourselves really for what might be coming rather than just suddenly have something appear and then for us to be able to respond to it. So this talk really is about a call to arms and basically for us to be aware of what's going on in the rest of the world and how we might, you know, uh, you know, respond and also prepare ourselves for the next big threats. And so this is called Unwanted Holiday Souvenirs. This was a title given to me by Neil. But I'll also explain to you why this isn't always a holiday issue, that this is also just a general issue that perhaps we should be a bit more aware of. Can we go to the next slide, please? And is this in viewer? For the things I'm seeing all of my slides? Yep. Okay. Um, so like I've sort of suggested, we've just come out of a reasonably static 4 years where we didn't really travel very much. We were sort of stuck doing what they like to call staycations. It's a sort of pet hate term for people who stay on holiday in their own country. But as long as it's not in your own house, you're not staying anywhere, you are traveling around a bit. Um, and we've known for a long time that when you travel, that whether it's in the country or whether it's mixing with other people, that you're likely to acquire infections. And these could be sort of just common colds. These could be SARS potentially if you out and about nowadays. And it's something that we as people who look after infectious diseases should always be aware that actually infections do travel around as well, along with us as their hosts. If we go to the next slide, please, Neil. And so we have to recognize as well that we're not just traveling for holiday. So holiday is sitting there in the middle. We're going away for a bit of our sun see and to get our vitamin D levels up. We also travel for work. So there's a sort of a picture up there of people with their sort of suitcases and their business suits. And we also travel for sort of immigration and emigration. So we're moving around because of work taking us to new places. And it may be that we're going to areas where diseases that we're not used to being in contact with are endemic in that particular area. And so over then into the sort of left of the picture or right of the picture, depending on how you're seeing this, is you also have the emergency responses. So a few of us over the years have also been out to areas where there have been epidemics of unusual infections. And of course, by doing that, you come into contact with people who are potentially infected with things that we are not so familiar with ourselves. And obviously at the bottom there, we have the issue with a lot of people coming in through refugees. I mean, we're seeing a lot of the world being sort of disrupted by war and by terror, and so people move in response to that. So you have huge movement of people coming from areas where potentially, in particular, vaccine rates aren't up. So you will see diseases moving in that area. So when we're talking about travel-related illnesses, you have to remember that we're not just talking about the holiday makers that might appear with a sort of a fever and a rash or whatever. We're also talking about lots of reasons that people travel. So next slide, please. And this is even more sort of come to play when we look at what's happened in the last few years. So we've just had a SARS-CoV-2 pandemic, whether or not that's still ongoing or whether we're into endemicity yet. Probably still could be debated, but by no means we recognise that the disease moved from one country into another, and as we travelled, we seeded the virus into other parts of the world. And this particular picture there of SARS, it shows you the genomic variation that we saw as the virus moved around the world. So you see lots of similarity initially, and then as the virus transmitted within the population, once it seeded into there, you see some of that genetic variation. And more recently, as we came out of the pandemic, we also had mpox moving out of Nigeria and into other parts of the world. And again, not just the fact that the mpox virus was moving itself, but the way it was being transmitted also changed. And so travel is significantly implicated in global seeding and onward transmission of all new infections, particularly when they come out of endemic areas. So next slide, please. So the first thing that we have to sort of get over when we're talking about travel-related illness, particularly for us in routine laboratories who are not specialist centres, is when you're investigating travel-acquired infection, we tend to conflate all tropical diseases, emerging diseases, as high consequence infectious diseases, and also the viral hemorrhagic fever. So they all become one in the same, and it becomes very difficult then for us as people who are not diagnosticians to essentially say, well, we want to be able to look for some of these infections without sort of having the concern, well, actually, well, what about if that person has a viral hemorrhagic fever on top? And actually, when you look at sort of the rates of the hemorrhagic fevers, they're actually quite low. We don't see that many hemorrhagic fevers transmitted in wider areas. If you recall from the Ebola outbreak, people were going over there and being exposed and coming back, but they had direct contact with patients with these infections. And so generally we knew that their risk was much higher than other causes. So it does, and because of this conflation, it suggests that all testing and management for all of these cases should be in highly specialized centres, which isn't reality, because a lot of these infections, because they are endemic globally, we will see them on a regular basis, and that they will not be coming in through your high consequence disease centre in all scenarios. Some of these will be coming in through your normal ED in your district general hospital, and so just to be mindful of that. And the problem then, what happens is when you sort of conflate it all together, you can hamper any future response should that disease begin to spread. And we saw that initially, certainly with mpox, where it was HSID, and we had to go through various routes to bring that down to a level where we could manage reasonably well in a normal district hospital. Next slide, please. So without a doubt, the pandemic had a significant, significant issue in terms of our ability to travel. So you can see here, during the pandemic period, that the UK travel trends during sort of the pandemic period stopped enormously. So we didn't travel very much. But as you know, and I'm sure if you speak to your colleagues, a bit of sun, I mean, it's not like the UK weather's been particularly good. So people have been traveling a bit further to acquire a bit of their vitamin D and to feel a bit better in themselves. And you can see that trend here. So this is a cut map up to 2022, but you can see that rebound after the pandemic period where people started to travel again, particularly in Europe and into other countries, so not just in European countries. So we are beginning to travel again, and so all of these issues that I'm raising actually should be back onto our radars in terms of what sort of infections we might see coming back into the UK. Next slide, please. So what I'm sort of proposing in this presentation is that really we should take up the reins of what was said to us in the beginning of COVID, is that we should begin to test and test and test. And the reasons that we're doing that is that we need to consider routinely testing some of our arriving travellers for key infections that have significant regions of endemicity. So viruses such as dengue and chikungunya, we know circulate in certain areas of the world, and people travel to those areas and come back, and perhaps they may have a fever or a rash, and it may be fairly mild, and it isn't always on our radars that we should perhaps be looking for more tropical infections. And actually, if you just look at where these viruses are endemic, it does generally rule out a lot of those hemorrhagic viral fevers if you are sensible in your risk assessment. So that's getting your clinicians involved in having a look at those patients and whether or not this is something that can be managed in a normal routine laboratory. And actually, malaria testing, if you look at those, so malaria is one of the sort of most significant infections that people have when they go traveling. It's the number one cause of a lot of the fevers that come back, and that is performed in most of our blood sciences laboratories. And that's even without sort of taking into the fact that some of these countries that they come back from will be areas where hemorrhagic fevers like Lassa fever do occur on a regular basis, but still they will do a malaria test locally. So if that can happen, why can't we be looking for some of the sort of lesser worrying viruses? The benefits of this approach are primarily for rapid management of that patient. And bearing in mind, when we talk about some of the testing, I am relates directly to molecular testing. I'm not really talking about serology, but we can talk about that as part of this process, perhaps in questions and answers. So really, we want to know immediately what that patient has, and we certainly use malaria testing as one of our differentials. So if a patient is malaria positive, you can generally stand down for a lot of other things because that will be the cause. But similarly, when you've been to somewhere where there's a dengue outbreak outgoing, you might want to rule out dengue as a cause of that particular infection. It also supports globally. So if you think about One World Health, which is a direction of travel which a lot of people are now talking about, if countries like the UK and other parts of Europe where some of these infections aren't endemic, if we start looking for them, then we also give an idea about what the transmission rates are to people who don't live in that area and how these viruses are moving around the world. And we can also give us an indication of early detection of new affected areas. And we'll come on to vector versus host transmission in some of my later slides. But really, by knowing that the virus is appearing in patients who are returning, you know that at least the virus is present, even if the vector isn't. And then what it does ultimately, it strengthens the laboratory and clinical response to emerging infections. And the way I've looked at this, certainly in the Cardiff aspect, because I'm looking at doing some of this testing locally, is that by starting to look at some of the lesser arboviruses, the ones that are more common and probably less risky, you can actually begin to normalize some of this testing in your local laboratory, and so people are less fearful of actually looking at some of these tropical diseases, and you begin to lessen that conflation between something which is a HSID and something which isn't, and especially by genomics, if you have that case, you can begin to then look at transmission dynamics and seeding into other countries. And this happens locally, but it also supports the LMIC countries to understand how infection is transmitting not only into sort of non-endemic areas, but locally within that population, because you can take all those first world methods back to those countries to support them in developing their own diagnostic skills. Next slide, please. So what tests do you include in this? I mean, this is a slide from 1998, and this is basically a slide to show all of the new viruses which emerge around the world, and there are many of them. I think each year there is a new virus described. We're using far more metagenomics to do this work, and so we're discovering viruses at quite a rate of knots. So, since 98, we've had things like, MERS emerge, you've had SARS emerge, you've had, dengue moving into new areas, Zika did amazing things, so there's all these changes. So it is very difficult when you look at a huge list of viruses about what you put in your first screens. So hopefully with a bit of discussion and my presentation, we can perhaps look at some of those issues. Next slide, please. So the first thing I did when I started looking at this locally to about what we can do in Wales, I looked at this paper here, and this was a paper looking at travel-related infections, and it's a retrospective study, and it was performed way back in 2014. So before we had our pandemic, and before all these things were of concern, and really, I suppose, before even climate change became a real issue for us and movement of vectors. The period that they looked at in this study was 2008 to 2010, and what they looked at was top diagnosis in 32,000 patients, and it was ranked by proportionate morbidity, so how sick these people were. And what they found was that most travellers that were arriving into Europe presented with gastrointestinal infection and obviously malaria. And I keep coming back to malaria because that's the one sort of pathogen that we've kind of accepted that everybody should be able to detect. And then we also had, 6% of those infections were illnesses acquired after travel in Europe. And we'll come back specifically to Europe as part of my discussion. And of those, GI is right up there, and respiratory infections. These are just your normal sort of standard seasonal influenza type viruses coming in. And as you can see, they're dengue. So dengue was being detected in Europe even way back in 2012, and 5 cases were detected then. Next slide, please. And this was basically looking at a different paper there, looking at the syndromic surveillance with what tests are being done in which areas, and this is neglected tropical diseases. And what they were trying to do is work out whether or not you were testing appropriately for the country of location that the patient had come back from. And, this slide essentially just shows that, you can test for a whole host of things and you can detect a whole host of things, but not everything will detect everything all at once. But right up in the top there, you can see dengue virus being one of the infections which was detected most often in most areas of the world. So you can see here that you can go for a syndromic approach, but what, again, would you include in that syndrome approach? Next slide, please. So dengue diagnostics is most widely used. The review showed this, and all of the syndromic testing shows this. So other significant arboviruses, so this is the group of viruses I'll be talking about a bit more in more detail later, from regions of travel was rarely requested, including chikungunya, except if the dengue was negative. So you'd often screen for dengue and then do chikungunya if you were next. However, so my computer is doing weird and wonderful things here. Bear with me. It's telling me Microsoft Outlook isn't working. Arthralgia is the most common in chikungunya than in dengue. So arthralgia, if you have somebody who's presenting with arthralgia, you probably want to look for chikungunya more than you do dengue. European travel, again, rarely triggered a request for an arboviral screen, except when CNS symptoms present. Even though 90% of West Nile cases present with fever, you don't always see CNS infections with West Nile infection. And we know now that West Nile is a problem in Europe. Tick-borne encephalitis, that has well on our radar at the moment. We know we've had 4 cases in the UK, which have been acquired in the UK, is very rarely considered. Tick-borne encephalitis is quite interesting because you do see, again, a spectrum of disease, and not all of it is related to the CNS. So you will have something called summer fever, which is common in areas where this virus is endemic. Arbovirus screening is generally sort of reserved for travelers arriving from Southeastern Asia with fever, and it's the first thing that a lot of people think of when people come back from Asia, that these people probably have dengue, and that, I think, would reflect most hospital and ID services. Most requests generally only happen during severe presentations. So the patient will present with very severe symptoms. So if you have somebody with a mild illness, if the respiratory screen is negative, then they're sent home. They don't think about testing for arboviruses. And so generally we think arbovirus disease is likely underdiagnosed globally. Next slide, please. So when we talk about arboviruses, we're talking about infections which are transmitted via a vector which bites us. So that can be ticks, that can be flies, or that can be mosquitoes. Next slide, please. So the basics of this, and so like I say, they're hematophagous arthropod vectors. So the mosquitoes, it would be the female mosquito. Ticks are just in general because they just like biting you, and then the biting flies. The biting flies are a particular problem down in southern Europe and into some parts of, other parts of tropical regions. But southern Europe particularly have some really nasty biting flies. They replicate efficiently both in the host and the vector. And there's a recent paper that's just been studied which shows quite nicely that Aedes aegypti, one of the mosquitoes which has been implicated not only in malaria transmission but in transmission of some of the arboviruses, that you can have up to 3 different viruses replicating quite happily within that particular vector. They're globally distributed and there are over 500 viruses described, but most belong to one of 4 virus families, which comes to problems when you're looking at some of the diagnostics. So the flaviviruses are a big group: Bunyaviridae, the toga viruses, and the reoviruses. Next slide, please. This is their sort of classical, replication cycle. So you have the enzootic sylvatic cycle, which is you have an invertebrate host and it goes into a vector. And in rural areas, that's something normally like a monkey, rat, rodent, or whatever. So you have this sort of normal cycle. And then what happens is that the virus or the vector move into the epidemic urban areas where humans become more likely hosts. So when you look at epidemics which occur around the world, you will find that the epicenter for most of them tends to be in the cities and in urban areas rather than in rural areas. So, actually, when you're reviewing your patient, if they've been to a city where there's endemic viruses circulating, they're more likely to have that infection. So you can see this sort of movement between epidemic urban, epizootic rural, and then the epizootic sylvatic cycle going on all the time. And so the enzootic, sylvatic rural and urban areas all replicate. You have birds involved, you have horses involved, and then you have humans and human to human transmission occurring as well. Next slide, please. So some arboviruses like dengue, chikungunya, and yellow fever have now adapted to make humans the amplification host. So what you will find is that they're far more better to replicate within us humans. So you end up in this epidemic urban thing. So when you have dengue and chikungunya outbreaks, and certainly yellow fever in Nigeria quite recently, you did see this urban sort of epicenter for some of these epidemics. So it increases the viral load for longer in us. We are very good at replicating viruses within ourselves. We then infect the vector because we don't tend to use nets, particularly for holiday makers who wants to sleep under a net and make sure they're covered in their anti-bug spray or whatever. So the vectors get infected from us, and then we can transmit to other humans as well. And there is non-vector transmission which can occur. Next slide, please. So these are the epidemic areas. So if you recall from the old textbooks, there's a lovely band around the world which we call the malaria zone, and it's like a belt which goes all the way around the tropical areas, and where they overlap really with the vector. And the vector primarily is the Aedes aegypti mosquito, and the Aedes aegypti is very good for most of these viruses, particularly Zika, yellow fever, and dengue. So you see this general overlap. Global warming, however, has begun to sort of move that belt, so it's less narrow now. So we're moving the vector further north and further south. So we're starting to see viruses that certainly wouldn't have been endemic in certain areas now arriving and becoming problematic in areas that you wouldn't have seen them before. And what we're also seeing as part of this expansion of a virus into the range is a variation in tropism. So we're seeing sort of new diseases emerging from a virus which was previously epidemic in one region. So Zika was absolutely classical case in this, where we saw Zika virus, which was originally sort of mild arthralgia rash causing illness very similar to chikungunya and dengue, potentially become a disease of neonatal and congenital infections with some severe outputs and outcomes regarding that. The list to the right of the screen shows you a list of all of the viruses which you could potentially put into any sort of screen, and also their mode of transmission. So you have the vast majority being mosquito spread, and then you have the tick-borne pathogens, and then you also have the flies as well. So one for Europe in terms of flies would be Toscana virus, which you get generally down into the southern parts of Europe, and particularly in Italy. And and in Wales recently we had a case of somebody coming back from Italy with a CNS infection caused by Toscana virus. Next slide, please. So if you just look at the global burden of dengue, so one of the things that you have to consider, if we're talking about the global One World Health space, is the burden of these viruses is not insignificant, and particularly with dengue and chikungunya in the Americans. And you can see that there are huge outbreaks which happen on an annual basis. And as we came out of the pandemic, particularly in southern Americas, we started to see epidemics of significant amount. And I'll just come on to the next slide in a moment. But also in areas like Pakistan and also Pakistan and other parts of Asia, we were starting to see epidemics of both dengue and chikungunya, and similarly lots of viruses circulating at the same time. Next slide, please. And so this is the current situation now. So this is dengue in the Americas. And what we've seen since sort of the 29th of March, so this is a slide I pulled down last week, you can see that the numbers now, so we're at week 12 at the moment of the epidemic in the South America areas, and we're already sort of 12 times more cases reported this time than there were this time last year. So we're already mapping the entire 2023 season for dengue virus with the Americas, and you know that places like Peru have already called states of emergency due to the amount of cases that they're seeing at the moment. And along with that is no less significant morbidity and mortality associated with these particular viruses. Now, there is a vaccine that has been developed for dengue, and it is going through rollout. One of the issues that you have with dengue, obviously, is that if you get an infection, a reinfection with dengue with a different clade, you have an increased risk of severe infection associated with that, including the hemorrhagic form. So when you give the vaccine, you have to give it to people who are, basically already have had dengue or not had dengue before. So you have to know the serostatus of that person before you embark on your vaccine campaign. Next slide, please. So the question is I've just shown you that we have massive outbreaks in areas where we know that they're endemic, but is this really a European problem? And when you're talking about a resource poor, NHS, or a resource poor sort of health service in general, and you're saying to them, well, actually, we want to be looking for these infections as well. It's very difficult to justify that. So really, I'm going to focus a little bit on Europe now, and in particular, this particular mosquito, and this is another Aedes mosquito, which is related to Aedes aegypti. So this is Aedes albopictus. When I try, so yeah, it's basically the Asian tiger mosquito, which is highly invasive. So it's arrived in Europe and it's doing very well in certain parts of Europe, and it's spreading across things. So next slide, please. Okay, so albopictus, and I'll say it correctly for once in my things. So this is a known vector, particularly of chikungunya virus. So around the world, we know that this particular mosquito is a good transmitter of chikungunya, but it's also a known vector of dengue. It's a competent vector, so that is, whilst it's not its usual host or vector, we know that if it becomes infected with these other tick-borne, these mosquito-borne viruses, that they will replicate well. So that would include then Zika, yellow fever, Japanese encephalitis, Cinvis virus, Rift Valley fever, West Nile, Myro. Myro is a North American virus, Eastern equine encephalitis, and so on and so on. And it is already linked to, local transmission of dengue in both France and Croatia, and also Italy. And the slides to the right, I don't know how clear they are for you, but it basically, the red zone shows how quickly this mosquito is actually establishing itself across Europe. So this was up to 2020, 2023, I believe. And you've already seen that we have found this mosquito in the UK, albeit it's never really established itself. So the issue is that it's not so much that it arrives in an area, so you can find the vectors in places, but what you want to do is whether it will establish a sustained population, because once you have a sustained population, and then with travel and somebody comes into an environment who has one of these viruses that can be a competent vector of, and that particular mosquito bites that person with that infection, then you suddenly have an infected vector, and then they can go on to then start that sort of cycle which I described earlier. So you have that sort of endemic cycle where you have infected mosquitoes spreading onwards. And next slide, please. And this is a sort of a cautionary tale. So this is Aedes aegypti in Madeira. So the vector arrived in Madeira. It established itself really well. So this is the first recorded mosquito was in 2005. It dispersed itself quite happily across Madeira, where it was living quite happily. And then what happened was that somebody came to Madeira and had dengue infection, and then you started to see dengue outbreaks occurring in Madeira. And there was some significant outbreaks which went on with high levels of morbidity and mortality associated with this particular vector. So you have to get on top of the vector really before you have the infection introduced to the country. And that is one of the challenges, and one of the reasons that we really have to begin to break down the walls that we have with working with people who are perhaps entomologists and perhaps One World Health people, to understand sort of that sort of cycle. West Nile, for example, infects birds. So if you suddenly have high bird die-offs, you really want to know whether that high bird die-off is because you have, for example, West Nile infection infection in the birds, and particularly if those birds are occurring in areas where you have a vector, then you have a risk to public health. So we all really have to start working together on this. Next slide, please. The problem with them all as well. So if you were to do a risk assessment for, say, we're looking at chikungunya, dengue, or Zika. So we've put down that as maybe our frontline sort of screen that we want to do for these arriving travellers. Well, they overlap. A lot of the symptoms do overlap, so it becomes really challenging. So the incubation period can be 3 to 21 days. If you recall, if you have a contact of one of these diseases, we generally sort of stretch it out to 21 days. Most infections of these infections are actually asymptomatic, so people don't know that they've had the infection. So you can have whole families who've been infected, but only one person with symptoms. There are three main acute presentations. So the febrile rash and or arthralgia. Like I say, arthralgia tends to be associated with the chikungunya, but that doesn't mean that it can't happen with the others as well. So in red, dengue and Zika, you have sort of that higher rate associated with the fever and rash, and chikungunya and is associated more with arthralgia, but they all overlap. Then you have the CNS infections, so West Nile Toscana, Powassan, Japanese encephalitis, and tick-borne encephalitis all can present with encephalitis, meningitis-like pictures. But that's not to say that they don't all present like that. And certainly West Nile and tick-borne encephalitis, as I've said before, can just present as something like a summer fever. So you get that when you've been walking around and you've been bitten by, whatever, and you've come back with a fever and it hasn't actually gone to your CNS, so you never know that you've had that infection. And then the hemorrhagic fevers, so Crimean Congo hemorrhagic fever, there's a little bit of that in Europe. And then obviously we've got dengue when you have your second infection or third infection with a different serotype. And then hepatitis, the yellow fever, you have the yellow fever, but you can get sort of a level of overlap between them all. Next slide, please. So let's talk about diagnostics then. So we kind of think, yes, I've convinced you that perhaps we should be a bit more aware of this and we should be perhaps looking for it a bit more, not only just to sort of diagnose those acute phase patients with severe disease, but also to understand perhaps a little bit more about how many times these infections actually arrive in the UK, to understand for surveillance purposes, are we missing them? Particularly should we get a vector which establishes itself? Do we have an underlying source for that vector to become infected with that virus? Next slide, please. So choosing it, so we start off with serology, because serology is actually the base threshold for most of these tests. It's widely used, and it's widely used not just in the UK, but in all. Right, I'm just checking my back. Yep,
Hi,
cool.
Catherine. I
Right.
can hear you. I can hear you.
Yeah, I tell you what, it's one of those days, isn't it? It's like maybe it's an arbovirus in my computer. So yeah, so like I say, let's go back to serology. So there were very few commercial options because of all of this cross-reactivity that you can see between viruses of the same family. And so they tend to be most appropriate in reference centres, and particularly in non-endemic regions when you haven't got PCR available. So when you have infections coming into the UK, you tend to see them, we send serology off to Ripple. Um, Antigen testing is an interesting one. So we're very used to using antigen testing with all of our SARS LFDs, and these are used quite extensively in the LMIC countries, and particularly for NS1 protein for dengue. They're rapid and their sensitivity is actually okay within the acute phase of the disease. So you can get a good handle on what infections are out there, particularly in epidemic scenarios. So very similar, I would say, to how we might have used them during the SARS pandemic. I mean, if you just come back to sort of what we would test normally in the UK, so we have a returning traveller and we take a sample from them, we've done a risk assessment, we know where they've been. Those samples go to Ripple, and I say serological testing is one of the key areas where these tests would be used, and that's largely because by the time we detect a person with them, normally 5 days has gone, and the best time for molecular testing, which I'll come on to now, is within the first 5 days of infection. So it's useful in the acute phase if we go to molecular testing. For most of us, it's now a familiar technology. We're very used to using molecular testing, and we can make these samples safe. So even in the the low probability of having something like a significant VHF in those viruses, we can make these samples safe by using nucleic acid extraction processes. So the lytic steps, for example, pre-actual doing the extraction. Commercial options are becoming available, and you can have single target up to really quite complex syndromic panel. More of them are being made. So since I've started doing this sort of investigative work and starting to do some implementation work into Wales, I've started to hear from other companies who are saying that they're looking in this area. So it's not just something that is a flash in the pan. I do think that this is something that everybody is recognizing as being something that most people should potentially be considering looking for. It is expensive for LMIC countries to use molecular technologies, and the way I look at this is the more that it's used in countries where these diseases are not endemic, it pushes down the cost for countries in like LMIC countries, because we can work on things like getting the commercial companies to respond. If they're producing more tests, then therefore the costs come down. So it's a mass produced thing. And also if we work on in-house testing, the in-house PCRs, if we're doing those as well, we can support LMIC countries into introducing that technology as well. So it's come down. So fundamentally, although serological testing is available, antigen testing is available, we would be looking at molecular testing. Next slide, please. Hopefully it won't freeze. So when we talk about laboratory safety, this isn't a new thing which is really coming out from WHO. So bearing in mind that the vast majority of these diseases that we're talking about, including some of the VHFs, occur in countries which are not the standard of us. We do not have, they probably don't have separate rooms. They probably have their patients in the same room as when they're doing their testing as well. So they've got their malaria screens going on and the patient sitting right next to them. So it's almost like point of care testing, but not quite. So what they've done, the WHO have done, is just looked at laboratory safety and taken it a new way of looking at it, and that is to risk assess it. Rather than just saying, well, that is an ACP category 4 pathogen, therefore you cannot do it in this area. They've said, well, rather than us reclassifying all these pathogens, well, maybe you should just look at your own facilities and actually make sure that you're using things like good laboratory practice, that you're using good PPE, that your cabinets are safe, and that your whole area that you're doing this work in is up to scratch. And actually, if you're working in BSL2, you should be able to handle a lot of things which are at a higher category level, because your BSL2 should be almost invincible. You do not want to get any infections. And bearing in mind that the BSL2 pathogens tend to be more infectious than a lot of these pathogens that we're dealing with here. So it's more about sort of risk assessing locally as well. And this allows you then to sort of expand some of the testing into other areas. I accept that that probably isn't the way forward that we would be looking at with UCAS accreditation and goodness knows what else, because I think we will hit barriers. But just to say that this is something the WHO have to consider, because these LMIC countries, the lower level countries with less resource than us, do also have to manage these infections safely as well. And if we can do it and they can do it, then we should all be working together on it. Next slide, please. So let's talk about the in my last sort of couple of slides, the non-vector transmission of arboviruses. And this is something which has been raised, and it was raised particularly with Zika virus, because what we were seeing there was sexual transmission of Zika, and there was incidents of people who had traveled to Zika areas, had been infected, came home, and then their partner became infected after close, intimate contact. Next slide, please. So dengue is, like I've already intimated, a real significant problem at the moment, particularly in South America and also into some of the Asian countries. We've got some huge problems going on at the moment. And this is just a little bit of evidence of the non-vector dengue transmission. So we take out, the issue with the mosquito having to be present. And so we've got some routes of transmission here, and you can see a couple of them are related to sort of like healthcare workers who were splashed in the face, for example, their needle stick injuries. I mean, let's face it, all a mosquito is a needle on a flying insect. So if you're sticking something into your skin, you're very likely to transmit that a virus. So healthcare workers, including laboratory personnel, have acquired dengue, after needle stick injury. Blood transfusions, that has been well documented, particularly in Brazil and America, with dengue 4 outbreak in Brazil resulting in transfusion transmission. So it's always something to remind you, if you've got high levels of transmission occurring in countries and people are coming back, it's not necessarily that they have to recognize that they've had a vector, they recall having mosquito bites. You should just be thinking about it anyway, because these things can happen. Bone marrow transplant, solid organ transplant, these are the well-known routes as well. So screening is part of that process. And then you've got the intrapartum and perinatal. So this is newborns with dengue virus. So we know it happens with Zika. We know you get intrauterine transmission with Zika. And then there has been, like I said, case reports with newborns who had acute dengue infections, and they have acquired it during the peripartum period. And then there are sort of like case reports again with the severity of that in infants. And then breast milk is another form of another route of transmission for some of these viruses. Um, Basically some sort of like mucocutaneous, and then there's some extrapolation with how you could, well, if it can happen this way, can it happen this way? So that comes to oronasal. And then sexual, there's been none reported to date at this particular point for dengue virus. But if we go to the next slide, you can see here that you can have dengue in semen as well. So when Zika became known as a disease that you could transmit sexually, somebody actually looked at persistence of dengue virus, and this is 2018 in semen samples, and you can see there that day 9 post symptoms that you were getting reasonable CT values in both serum, urine, and also in semen samples. And actually, if you look at that top line there, you can see CT values compared to serum versus semen was actually slightly higher. So actually there's good transmission risk, and it carried on up until day 37 in this particular case. And so you can see then that although they couldn't detect infectious particles in this particular things, theoretically, you could potentially see the risk there as well. And certainly with Zika, it was well reported and clearly documented as a disease through sexual transmission. Next slide, please. And these are just some other infections which have been looked at in terms of sexual transmission. So your partner's gone over to one of these countries, either traveling or they've been, responding to an outbreak, and then they've come back and things. So there's a case report there for Crimean Congo hemorrhagic fever, and then also chikungunya, and then sort of a prolonged shedding in semen and in urine, with implications there. There, West Nile meningoencephalitis, a nice case report there with somebody who had a meningoencephalitis, and their only contact was with somebody who they had sex with, and probably acquired their infection that way. Next slide, please. So can arboviruses be STIs? Well, yes, but only in certain circumstances, and it's likely to be short-lived, but it's something that we should perhaps also consider when we're doing some risk assessments. And if you've had somebody who's traveled and then their partner becomes ill with an illness that you can't sort of diagnose using routine standard testing, then perhaps, it might be worth looking at, what the risk factors might be. Case studies that have shown sexual transmission rates do suggest that the symptoms may be more severe. And I suppose that's because you're getting a higher viral load. It's not a mosquito infecting you, your higher viral load earlier on. And then the burden of such transmission is difficult to quantify. And I suspect, if we had a bit better surveillance going on, particularly in areas that are non-endemic, where you can be a bit more astute about what the route of transmission was most likely to be, you might be able to get a bit more information about some of the transmission, particularly to feed back into epidemics when you have these out of control, which look like, giant epidemics, about some of the risks, that don't just require, a vector to transmit onwards. Next slide, please. So, summary, very small writing. So a clinical history of a patient presenting with acute infection should include travel history and consideration given to type of travel and those exposure risks. And, most symptoms, let's not forget that travelers present with are caused by common infections. So you don't want to stop doing your normal routine testing for the common infections because you're holding on waiting for the weird and wonderful that they could have also possibly come back with. Non-specialist labs historically test only for common infections and malaria. And I think it's the malaria that we really have to sort of really remind ourselves of, that our blood sciences laboratories, which are not, infectious diseases laboratories, have been testing for malaria for decades. And they do it, on and off, and some of these patients no doubt will have come in with other infections as well, although do not tell blood sciences that. And we have more specialized testing for, going on in reference centers for a lot of the infections, even though malaria is done locally. So my sort of question then is whether we should consider testing more widely for infections associated with travel to facilitate that patient management, because you can get a result faster, bearing in mind as long as they're in the acute phase if we're using molecular testing. And the concerns about laboratory safety can be largely overcome with robust risk assessment, and that's local risk assessment and the use of molecular testing, and knowing that you're testing the processes that you're doing will inactivate a lot of these viruses. Syndromic panel testing to cover the major causes of arboviral infection could represent a step in this direction. And I'm not suggesting that we do CCHFs or Ebola or go in straight away like that. But certainly things like dengue, which is the most common cause of, non-malarial disease coming in, could be considered as part of your frontline screening for these arriving travellers. By covering infections with a broad geographical range and overlapping symptoms, you negate the requirement to target by geographic illness. So we know that dengue occurs globally. We know that Zika is fairly global. And we know that West Nile is potentially global as well. So you can choose your panel to be as broad as possible without actually sort of being as type specific, based on their location. Despite the huge economic and disease burden caused by the arbovirus, they are largely underdiagnosed, particularly in arriving travellers across Europe. So European studies, I mean, the study I looked at from 2012, I don't think we're any further forward. I was involved recently with looking at a study in Italy, and they were specifically looking at arbovirus infections. And that's really, even though Italy has a known problem, they also need to step up their diagnostics and surveillance as well. So even when we know there's a problem, we still dramatically underdiagnosing that, and bearing in mind, remember Europe when you're looking at this. This additional data will further inform about unusual disease presentation, incursions of disease into new areas, which is the most important thing when we're talking about emerging infection, and also unusual modes of transmission, whether that's through sexual transmission or through neonatal congenital infection. And it also supports data for vaccine rollout. I mean, like I said, dengue has a vaccine. It's limited use, but it will be successful. Malaria certainly has a good vaccine rollout, and all of the data about sort of infections outside of the local hosts, and how it's transmitted around the world will help that vaccine effectiveness data. But importantly, global warming, we can't sort of forget that, and the move of competent vectors, Albopictus into Europe, and Aedes aegyptus into Madeira, taught us a harsh thing, that these are invasive, and when they establish themselves, the disease just has to follow, and then we've got a problem. And so the infected arriving travellers can provide a source of infection to the vector. So increasing testing in arriving travellers, including those with milder disease, don't just think about flu, will inform the unseen movements of these viruses globally. Next slide, please. And this is just a slide from APFA, just showing you that climate change and the number of cases of diseases that occur due to vector-borne disease around the world. Fact that even our local diseases like Lyme that we know about, the number of cases are doubling all the time, because ticks are able to survive in the environment for a lot longer. And next slide. And I think this is my last one. And so, like I say, think global, one world health. And thank you.
Thank you, Catherine. That was very informative. I'll have a look at the questions in a moment, but I've certainly got one. A lot of these viruses that you've been talking about are on the WHO neglected pathogens list. And do you think in the UK we're ready? Because as we've sort of indicated, they're coming our way due to global warming and with the opening up of the travel routes. Do we need to think about diagnostics not just in the reference centres, but out in the out in each of the labs? We've got lots of molecular specialists now, certainly post-pandemic. Just interested in your thoughts on that.
I think yes. I mean, this is why I'm sort of quite happy to present this, and just sort of say a call to arms. Really, I think it's a grumbling, insidious threat that we're not quite ready for. I think the fact that we've had tick-borne encephalitis already in the UK, and this was acquired in the UK, suggests that that it's only a matter of time. Like I say, Europe are already seeing dengue and chicken. They're seeing it in Italy, and we just don't even think about it. People come back. Our Toscana case, I mean, it was diagnosed eventually, but it wasn't sort of like the first line thing you think of. But when you know about these diseases and you say, well, they've had traveled to Italy and they've come back with an encephalitic like picture, you think, well, actually, have we looked for Toscana? I think it's just be prepared, and I think we've all had to, mpox, case in point, we all had to step up and prepare for mpox. We all had the technology. It wasn't that hard, to move a test from a reference lab into facilities that could test for it. Let's just be one step ahead this time, so that we're not only ready for it, we've also got some surveillance. We know what's going on in the UK. We know we've got absence of infection, or we've got some infection, so that when the vector arrives, we're already there with that information ready to advise.
Super. And I've just got one other question from Mary. Why is malaria testing done in blood sciences?
Oh, it's because they make films. Yeah, they make nice films. You've got
it's blood
skills to make the
film.
films. Yeah. It's a blood film. It's yeah. I mean, the fact they've got to do an LFD as well, that's, you know,
Yeah.
that's actually, yeah, I mean, I don't know, it is though, and they count
Yeah.
the number, don't they, the burden of your load, you know.
Yeah. Okay. Thanks a lot, Catherine. Just to let everybody know that at ProLab Diagnostics, we cover the ViaSure range of RT-PCR assays, and we cover just about all of the viruses that Catherine's been talking about, both as in a monoplex or a multiplex. So if you're interested, I'm sure you can contact your territory manager, and I'm sure that they may be in contact with you in the next few days just to follow up to see what you thought about the talk. I'd just like to finally thank Catherine for taking time out of what was a fantastic talk, and from the comments coming back, people are very interested in this. So thank you very much, Catherine, and I hope everybody managed to get a sandwich during your lunch. Okay.
Yeah, and I'm sorry about the IT issues.
Yeah, and sorry for not presenting in presentation view. Once I'd got it going, I just didn't want to change it because I didn't want anything else to go wrong.
I'm kind of glad I
so we'll
wasn't
be
presenting
slicker
you, because I would
next
have just
time.
failed.
Yeah.
Yeah.
Okay.
Okay, thank you very much.
Thank you very much, everybody, and thanks a lot, Catherine.
Thanks. Bye-bye.
Bye.